who allow me to share about the finding a ray of light in the Fallot's despair, how to stand beyond the future. So RVOT standing procedures is just like flying through out the storm, but it could give a ray of hope to tetralogy Fallot's patient. So usually tetralogy of Fallot is coming to our practice in the early of life. But it different in Indonesia that the 60% patient come to us with a late presenter. Actually, as the incidence is 7 to 10% in all congenital heart disease, the goal is the total repair. But 25% of the patient cannot go to the total repair since a lot of problems. First, the diminutive of the pulmonary artery size, confluence of the pulmonary artery, and the late presenter that we will find the low ejection fraction. So that those population need palliative procedures, and classically the palliative procedures goes to surgical procedures. But ventricular dysfunction and reoperation are important risk factors for mortality and morbidity in cardiac surgery. So, shall we go to the non-surgical intervention? An LV systolic dysfunction in cyanotic congenital heart disease is a preoperative threat. There's a causes of the LV dysfunction, but mostly it goes to the chronic hypoxemia that occurs in the late presenter Fallot. And you can see here as a comparison in the literature said that modified blood toxic Thomas shunt compared to the RVOT stenting, it shows a better option of the RVOT stenting since the mortality and is comparable but less hospital stay. Another issue for RVOT stenting is valve sparing versus valve stenting. So we have to prepare. Shall we spare the valves since some critical Fallot have a very small pulmonary artery damage. This is our publication from Indonesia that shows the RVOT stenting can be done in adult congenital heart disease and having good hemodynamic and clinical profile results. RVOT stenting can improve both oxygen saturation and left ventricular ejection fraction in the late presenter. In adult congenital heart disease, double RVOT stenting could be an alternative due to high distortive force. This is our single experience in Harapan Kita, Indonesia, that the saturation is improved and better ejection fraction. So RVOT stenting is a safe and effective method, not only in newborn infants, but also in the late presenter, including adults with unrepaired Fallot. So this is our publication in our center, comparing the RVOT stenting and BT shunt in the late presenter that showed the RVOT stenting is a palliation to stenotic RVOT in children, showed comparable outcome in to modified BTT shunt in terms of MACE and achievement in the oxygen saturation target in patient older than 1 year. So another problem also in the complex lesions such as tricuspid atresia physiology that RVOT stenting can be done. This is our case in Indonesia. First, this is a 18 years old girl that's have a nearly spell hypoxic with the saturation is very low, it's only 40%. You can see the RVOT is very, very tight. And we first dilate with the coronary balloon by crossing by a coronary stent. After that, we change to the soft hydrophilic wire zero with the 35 system, and then followed by the putting the vascular stent. And the follow-up showed the ejection fraction is increasing after the RVOT stent compared before of the with the before procedures, and the saturation is increased up to 98%. This a case with 18 years old male with the Fallot. In the couple of days, the doctor in charge called me that the patient got desaturation again. You can see the stent was cramped, and you can see from the TE, the stent is cramped just in the RVOG on the tight input dural. So I put rewiring and then put another stent, and the patient is stable, and now the patient is uh, already have a total repair. This the current follow up also the ejection fraction is increasing. Uh, Another problem. How about the if we have some uh, uh, accident? You can see this is our first RVO standing in adults. Eventually, the I put the stent is quite too low, and then the stent got dislodged to the RV, and I did another RVO stenting and grab it and put it in the right atrium, and I asked the surgeon to make a tabak sac to remove the stent by right auricle. This is our experience also for the RVO stenting in the tricuspid atresia. We have three experience of having RVO stenting in tricuspid atresia, but one of the patient got suffered of the total RVA block because of the stent crammed to the AV node. So this our last patient. We did the RVO stenting in the single lung experience. You can see the patient suffer of the recurrent spell, but there's no left pulmonary artery. So we did the cannulation by the coronary wire, and then after that we did the lesion preparation like in a coronary technique, and then I put the vascular stent, and you can see after that the flow is good. The saturation increased from 28% to 90%. And I checked for the left artery. There's no stump at all from the descending aorta. So before I uh, close this presentation, RVO stenting is a preferred strategy even in patient with a complex anatomy. RVO stent is now indicated in the late presenter and even adult patients with a good results. Thank you very much.